This is our continuing ICM lecture series with chest radiology, and we're going to talk about the findings on the chest x-ray that we're going to call opacity, and that can be a little bit confusing to get a handle on. And so what are we talking about? Well, we're going to typically be talking about something that has some altered density, some greater density than typically seen. And so what we'll be looking at is things on the chest x-ray that may suggest a mass, may suggest some sort of consolidation in a lobe or a segment, could represent pleural effusion or atelectasis, and that of course would mean volume loss. So some sort of increase in density in the chest x-ray. Our general term we're going to use, we're going to call that opacity. So let's just work through that and talk about masses and nodules first off. And I think with masses and nodules, patient age and history is key, and then these other things, as you can see, how many, where they are, whether calcified, etc. So single or multiple. Sure, if there's one lesion there, we might be thinking more about a primary malignancy, and if we have multiple lesions in both lungs, we may think about metastatic disease, or at least hematogenous spread of disease from some other source. All right, so that could help us in that regard. What else might help us? Well, if we see a nodule or something out in the periphery of the lung, if it's calcified, typically that's a pretty good sign for a benign lesion, and sometimes we can even see the density numbers on that on a CT scan and the density numbers would have an elevated number, a so-called elevated Hounsfield unit number, but again, calcification supporting benign process and stability over time. Here's our nodule. Looks like our arrow slipped a little bit here. Here's our nodule, and we can see it over here, but over a 3-year period, the nodule hasn't changed, so that stability over time is really supportive of a benign process. So what else would we look for? Well, with our imaging now, with the FDG or the PET imaging showing radioactive glucose uptake, a lesion that's metabolically active, that's certainly much more worrisome to be a malignancy. Those may be ways we might characterize it. Other ways we'll characterize masses are just by the locations. I mean, we know from just what we've seen before, that's that upper mediastinum, and we're going to have to think about thyroid lesions there. Lesions in the hilum, we could worry about adenopathy or some sort of mass there, so the location can help us out a little bit. Again, here, a big mass or some sort of mass effect. Look how that trachea is bowed. We know the aorta is right there, so that location can help us out a lot. Bilaterally, we're seeing here in both hilum, so we'd think more or less about adenopathy, some sort of process that might enlarge the lymph nodes. So those locations can help us a lot too. So continuing on with opacity, what about consolidation or airspace disease, or whether we're going to call it alveolar disease as airspace and interstitial disease? Those are manifestations of that increased density or opacity, but we'll talk about consolidation. And typically we're going to be looking for things that could be pneumonia, but realizing that hemorrhage or edema or even aspiration, all those could give a similar pattern or appearance on a chest x-ray. So what can we look at? Well, we can look and see that's asymmetric, right side versus left side, and from the lateral view we can localize that posteriorly, and we can realize that that's pretty much the whole right lower lobe, so we'd worry about pneumonia there in the right lower lobe. Similarly, corresponding here and here, we'd worry about something in the right middle lobe, maybe pneumonia going on right there. And so we'd want to catch that early on, because if it sat around there and smoldered, it could cavitate, actually turn into an abscess. And here we've got that liquefied air and fluid of that cavitary space in that right middle lobe of that pneumonia progressing. And from our appearance right here, knowing that sharp outline right there and understanding that minor fissure, that should help us tell us that that's in the right upper lobe. Other areas here, again, we're not seeing that diaphragm. We got a little more density here on the right than maybe on the left. That lateral view can help us show us it's in the right lower lobe. So those locations, judging by fissures and which lobes and segments are involved, can help us. Now, we can sometimes see density bilaterally, and is this respecting a lobe or a segment? Well, not really, and is it bilaterally? And so that edema process can also be due to something causing leakage of fluid into the lungs. Heart failure is sort of the prototype. We'll be talking about that more later in the cardiac section, but again, unilateral disease, we may be thinking more about an inflammatory, infectious process. Bilateral disease, we may be thinking more about alveolar edema, whether that's cardiogenic or non-cardiogenic. We can also get areas that are not completely consolidated and filled up completely, but we may see thickening of the interstitium, that interstitial septal area there. Here we're seeing some edema tracking along that interstitial lobular area, and we can also see it something like, here's our friend here, a younger person with cystic fibrosis, and that chronic inflammation there has had that thickening developing all through the interstitium there. So alveolar disease, airspace disease, or interstitial disease, those are ways we can characterize it. So if we think about opacity, we can also think about atelectasis, and it can look a lot like the consolidation, but the hallmark of atelectasis is going to be volume loss. There's going to be decreased volume in that lobe or segment, and the decreased volume is because the lobe or segment is airless now, as opposed to being filled up with some infiltrate or some sort of pneumonic process or fluid. And so what we'll see is the opposite lobes will compensate and become hyperexpanded, and the fissures will shift. The mediastinum may shift. One side may shift completely over to the other side. And if we look hard, we can sometimes see the ribs are closer on the atelectatic side and perhaps spaced out a little bit more on the hyperexpanded side. And a lot of times it's a rapid onset because these people might be in the hospital and have a mucus plug, or one of our tubes may have gotten down a little bit too far. So what might we see? Well, post-operatively, a lot of times people just aren't breathing quite as well post-operatively, and we may just see these little areas of linear density in the lungs, so-called subsegmental atelectasis, and a lot of that will just clear with time and maybe a little encouragement of some deep breathing. But if we've got our endotracheal tube going down the right main stem bronchus here, we're getting no air in that left lung, and that entire left lung is atelectatic, as we can see on the CT scan here in another patient, entirely atelectatic left lung, and we can see how that mediastinum and that right lung is shifted over, and the heart is shifted over. So that's that shifting of the mediastinum here with a mucus plug just in the left main stem bronchus. And it can happen rather quickly. Here's our friend here. One day had their ET tube appropriate and everything looks fine. The very next day, ET tube is slipped down and that entire lung is atelectatic. So these can happen rather quickly. What else might we see? Well, we might notice that the left hemidiaphragm is elevated. So that's telling us there's some volume loss. So that phrenic nerve injury and that elevated diaphragm is volume loss, and there's some atelectasis. Here we're seeing that minor fissure sequentially as there's getting some atelectasis in that right upper lobe, and that fissure is elevating and going up further as that right upper lobe is becoming more and more atelectatic. The right middle lobe, because of its location and triangular shape, it can give a pretty characteristic appearance on a lateral x-ray. It's easier to see that atelectasis of the middle lobe. So that atelectasis is going to be density on the chest x-ray, but that hallmark is that volume loss. And one more here just for good measure, this triangular shaped area here, you know, that's medial to the left heart border. That really shouldn't be there. And that's an atelectatic left lower lobe right there. That lobe not getting any air and is completely collapsed there. So that covers our atelectasis portions of it. And since we're talking about density or opacity, other things we have to think about might be pleural effusions. And what might that pleural effusion look like on upright or supine or decubitus views? Well, upright might just have a little bit of blunting of the costophrenic angles like that. Certainly could be larger, like with this larger right pleural effusion. Sometimes we'll call it subpulmonic if it collects along the inferior aspect of the lung, and there's increased space between the lung and the diaphragm, and we can turn the patient on their side, decubitus, the right side down, or right lateral decubitus, and we're seeing that free-flowing pleural effusion with our decubitus view. Sometimes the supine view is a little bit hard to tell exactly how much pleural fluid there really is there. Well, we know there's some. That diaphragm looks a little bit elevated. The CT scan can show it really is a very large pleural effusion, and really portions of that right lower lobe are atelectatic there. That effusion is taking up space in the lung, so there's not as much space for the lung to be ventilated. So that atelectasis really travels with the effusion. We might say the two things are not really separated. They travel together. So if we've got a big effusion, we're pretty much going to have atelectasis to travel with it. And if we looked at ultrasound, we might see that atelectatic lung sticking up right there in that big effusion. And you know, if you look at ultrasounds too long or stay in the dark with a radiologist, you start seeing things, and you know, that looks like, I guess, the shark fin maybe now because we're hearing so much about sharks. But I guess I looked at it years ago and I saw it kind of sideways, so I thought it kind of looked like the elephant's trunk. But again, that's probably just sitting in the dark too long. Alright, so we can have these big effusions, and sometimes they can be rather large, and if they ever need to be drained, we can use the ultrasound as a guide, and a thoracentesis, the needle can go in between the ribs there, and that fluid drained off to evacuate and improve ventilation. And sometimes the worst thing could happen be that pleural effusion could get infected, as we're seeing here. This is that big kind of loculated pleural effusion, and on the CT scan we can see it here. But it has air in it because it's now an infected pleural effusion or an empyema, and we certainly need to get that thing drained. And trying to figure out that difference, sometimes that lung abscess that we saw earlier and that empyema can look similar, but the key features are that the empyema we want to drain out from the chest wall and drain that infected pleural fluid out, and the abscess or the lung abscess, we want bronchoscopy to try to establish ventilation of that lobe or segment to get that one to drain internally. So there's a big difference in whether we have an empyema, infected pleural fluid collection, or a lung abscess, how we would manage them. Other things can happen in the pleural space. There can be sometimes we can have plaques. These calcified plaques or soft tissue plaques can develop, especially in people with asbestos. Sometimes we might see that the pleura doesn't go up all as far as it does typically in the apices, and we might worry about an apical mass because that pleura doesn't seem appropriate or it seems too thick up there, as we're seeing with our friend here, unfortunately, with their superior sulcus pancreas type tumor, and TB, because that reinfection TB affects the upper lobe. Sometimes we'll see that apical pleural thickening and some of that irregular density, but again, following that pleural lines along there, it may not be effusion, but it'll be some asymmetric pleural thickening that really shouldn't be there. And what we would really worry about if we ever see something like this with this lobular pleural thickening all along the chest, and here we're seeing it on that CT scan, and this is that mesothelioma that's associated with the asbestos exposure, and we're looking at the specimen here from a radiographics article, and there's that tumor infiltrating along the pleural space, and there's that PET scan showing that increased activity all along that pleural space. So if we're trying to look at this maybe as a good way to think about it, we've got two patients here, and one of them needs bronchoscopy and one of them needs a thoracostomy. So one of them needs to have the pleural fluid drained and one needs bronchoscopy. So if we look at those two, can we tell? Well, they both got white. One side of the lung is white and black on the other side. So how would we decide? Well, if we look at this one, we can see the mediastinum is shifted. So the mediastinum is shifted towards the opacified side, and that's telling us that's volume loss because the mediastinum is shifted toward the opacified side, and the contralateral side is hyperinflated. So this person needs bronchoscopy to try to get that left lung better ventilated. Our friend here, if we look at this, we can see here's the trachea right here, and here's the carina, and it's being shifted away from the opacified side. So that's a big mass, and we can see this is a big, huge pleural effusion that's filling up that right hemithorax, and there's that collapsed right lung, and all that mediastinum is being shifted away. So if we see the mediastinum shifted away from an opacified hemithorax, we're thinking about pleural fluid or mass, and that needs a thoracostomy tube typically. And if it's shifted towards, like our friend over here, shifted towards the opacified side, we're going to think about bronchoscopy. All right, so that kind of summarizes that, and we've talked a little bit about some of those procedures. Ultrasound for thoracentesis. We can also use ultrasound for venous access for central catheters. We can use it for biopsy of masses and pneumothorax treatments. So here's our trusty radiologist doing the biopsy of the mass there against the chest wall. And so typically if the lesions are more in the periphery and adjacent to the chest wall, radiology, and we'll try to biopsy one under CT scan, whereas sometimes if it's more central, the pulmonary fellows may look for it with bronchoscopy. So here we're again seeing that thoracentesis being done. So I guess if we summarize things and think about opacity, we're talking about alteration in density on the chest x-ray. And we're trying to figure out, is this mass? Is it some sort of tumor, some sort of nodule or mass, or is it some consolidation, some process filling up a portion of a lobe or a segment? And sometimes it's a little bit hard to tell, but we try to maybe make that distinction, and then we're going to look and see, well, could this be pleural fluid? Well, is that a pleural effusion? What could we do? And does it have a typical feature of a pleural effusion? How does it act on decubitus fuse? And realizing also that because the atelectasis can look similar to consolidation, we're going to always look for volume loss. Is there volume loss, decrease in volume, shift of mediastinum, or fissures, and is there an appropriate history that would tell us something that this density in the chest is really related to atelectasis as opposed to some sort of consolidation? Again, let's pay attention to the history, and I think that'll help us out a lot, and hopefully that summarizes everything. Thank you.